Hi, my name's Charlie, and I wanted to tell you about a very specific way that the funding from SPHR has influenced my research. So with NIHR funding comes an imperative to develop patient and public involvement activities to inform your research. So during the first year of my PhD, in parallel to conducting a literature review and speaking with professional stakeholders, I spoke informally with 13 women with lived experience of perinatal mental health conditions. And I did this not because of an NIHR mandate, but because I believe that research, it should really be grounded in the needs and priorities of those who are most affected by whatever condition or phenomenon that we as researchers are studying. So I made contact with women and I shared with them an accessible summary of my draft research plans. And I decided to speak to them one-to-one as I thought that would be a more inclusive way of engaging. From an equity perspective, it was also really important to me that I spoke to women who had experienced different forms of mental illness, as well as women from different socioeconomic and ethnic backgrounds. And funds in my award meant that I was able to give women a shopping voucher, as a small token of thanks for their time. Training from SPHR has really underlined the importance of keeping people informed. So after I'd got ethical approval, I sent a written update to women detailing what others had said, in terms of broad themes and changes that I'd made. And women really, really appreciated it. Women were incredibly generous with their perspectives, and I want to share with you now a little of what these conversations revealed. So this slide shows things which were really important to women, which they thought could be better understood, or things that they thought shouldn't be forgotten. And I just wanted to put these side by side with the areas for future research, which was suggested in a recent review on the field. And I think this highlights some of the tensions in how researcher priorities and women's priorities, sometimes they align and sometimes they don't. And an ethical dilemma for me was how I could justify what I wasn't able to take forward, and to really think through how I went about. So these conversations, they challenged many of my assumptions, and lots of things changed as a result. But I wanted to tell you about a really specific methodological example in a bit more detail. So this area of research is a highly sensitive one, and research literature indicates that using creative approaches in interviewing can enable the discussion of difficult or painful topics. During discussions with women, it became apparent really quickly that probably wasn't actually going to work. So I asked women what they thought about being asked to bring along photographs or drawings or small objects to the interview, so that they were able to start their story wherever they wanted. And many said that they liked the idea of being in control of where to begin, but they weren't too keen on bringing something along with them. Some said that it'd be hard to find the time to think about what to bring alongside caring for the kids. Some said that they'd find it stressful thinking about what the right thing to bring was, or that it could be a painful process to work through too. So as well as sending regular updates to women, in the future I'll be working with 4 of the 13 women to be testing preliminary findings and theories, and women will also have input into the topic guides for the focus groups with professionals. And I'll collaborate with them to create dissemination materials for women, health professionals and the voluntary sector organisations. So I want to conclude just by saying thank you to my supervisors and also to the women who spoke with me and were so generous with their time and perspectives. Thank you for listening. Please get in touch should you want to know more about this work, or to share any insights from your own work in this area. Thank you.
Hi, I'm Claire, and I've just started the second year of my PhD at the University of Bristol. My PhD is joint funded by the NIHR School for Public Health Research and DarkWest. In this short presentation, I'm going to explain the background to my project, my progress so far, and my plans for the next year. I'm researching relationships and sex education in schools, known as RSE for short. There's been a recent change in the statutory guidance for this in England, which follows many years of concern about the quality, coverage and relevance of RSE. In 2020, the UK government updated the curriculum and made it mandatory for all primary schools to provide relationships education and all secondary schools to provide relationships and sex education. The relationships education part of the curriculum is compulsory at all ages. However, parents retain the right to withdraw their child from sex education until 3 terms before the child's 16th birthday. At this point, the young person can opt back in if they wish. It isn't known how many young people are withdrawn from sex education, nor is there a system of routine data collection for this. And that's where my PhD comes in. The main aim of my PhD is to find out how many children are withdrawn from sex education classes and understand the reasons why parents might do this. The first project of my PhD is well underway. In this, I am systematically reviewing quantitative and qualitative evidence of parents' attitudes towards school-based RSE. In my second project, I'm using survey methodology to describe withdrawals from sex education, and we'll look at this in a bit more detail in the next slide. My third project is a qualitative study. In this, I'll interview parents, students and school staff to understand the psychosocial and environmental determinants of parents' decisions to withdraw their child from sex education. Now I'd like to speak in a little more detail about the protocol I'm currently developing for the second project of my PhD. The survey has 2 main objectives. Firstly, to determine the scale of the issue, how many children are withdrawn from sex education, and how many parents are raising concerns about the RSE curriculum as a whole. Secondly, I'll investigate whether the rates of withdrawals and concerns are associated with characteristics of the schools and pupil demographics. The survey will be delivered online, and the target population is all schools in England for children up to 16 years. For the sampling frame, I'm using the Department for Education's Register of Educational Establishments in England, which includes all types of school, including state-funded, independent, special schools and pupil referral units. This register also contains school-level data such as the number of pupils, Ofsted rating, whether the school has a religious character, and the number of pupils receiving free school meals. Without an existing estimate of the withdrawal rate in the UK, it has been difficult to find a meaningful approach to calculating the sample size. Given that the survey will be distributed via email using the freely available school contact information from the online register, it is possible to automate much of the survey delivery process. Therefore, it seems feasible to survey all schools, at least from a resources point of view. As part of my protocol development, I'll be working with public contributors from schools, as well as parents and young people, to gather feedback on my plans. Definitely the main challenge in this project will be to recruit schools to fill in the questionnaire. To address this, the questionnaire itself will be short. By linking schools' responses with the routine Department for Education data, I can reduce the number of questions asked. I'll also incentivise participation by offering the school entry into a prize draw. I'm going to begin this project with a local pilot, delivering the survey in a small number of different types of school to test the approach to data collection and evaluate the response rate. I'll also interview respondents and non-respondents to understand their experience of the survey and to determine whether a full-scale study will be feasible and return meaningful results. Thanks so much for listening. I'd really appreciate any questions, comments or feedback, so please do speak to me at the Expo or email me at the address on screen.
Hi, I'm Joanne McGrath, PhD student at Northumbria University, and this is a snapshot of my research looking at how women with multiple exclusion navigate services. These are some of the aims of my project. Multiple exclusion refers to simultaneous issues which can occur in people's lives, including homelessness, substance misuse, poor mental health and domestic violence. Research suggests that women experiencing these chronic issues tend to avoid services, and I'm hoping to shed some light on why that might be the case. Using a timeline approach, I've conducted 20 semi-structured interviews with women in Gateshead. One of the advantages of using this approach from a researcher's perspective is that it helps to make sense of often quite complex stories. Another advantage is that a timeline can create a collaborative space with the women actively engaged in the interview process, and it can have a sense of depersonalising quite sensitive personal issues. This is the timeline of Sarah, one of the women I interviewed. Her story illustrates how multiple disadvantage can occur and quickly become entrenched. Sarah first started using substances after being taken into care as a teenager. The next few years were spent living with her nana. However, when her nana died, her only source of support was gone. She struggled to cope, and as she says, "I lost my home, I lost my job, I lost my kids, I lost everything. There followed after this a 10-year period of homelessness, escalating substance misuse and poor mental health. Traumatic experiences were a regular occurrence, and substance misuse was a way to cope, to forget and block it out for a while. On the chart I created to illustrate her story, the purple stars represent trauma, the gold stars where she's had support from services, and as you can see, support was fragmented and patchy. Sarah ended up in hospital for 3 months following an overdose, and here at last was referred to specialist services for her ongoing issues. However, she still didn't end up getting the support she needed, and as she said to me, they should have actually sat and talked to us a bit, or asked us how I was feeling, even spoke about things like this, and then maybe they would have known how to help. Do you know what I mean? The next stage of my research will be a thematic analysis. Emerging findings highlight the importance of early intervention and how substance misuse can exacerbate existing problems, isolating people from support and creating barriers for women accessing the support they need. My experience of doing these 20 interviews was that far from being hard to reach, these women were really keen to share their stories, to be heard, and hopefully shine a light on the gaps in the system. Thank you very much.
Hi, I'm Catherine Parkin and I'm in my second year of a PhD in Public Health at the University of Cambridge. The overarching focus of my PhD is adverse childhood experiences, sometimes referred to as ACEs, and the impact of them on childhood mental health. The research team I'm part of is exploring whether it's possible to develop early identification tools to predict which young people might be at risk for developing mental health problems. If we can successfully identify these young people earlier, then timely and proportionate support can be offered to help them. To develop these early identification tools, we're using linked, routinely collected data from health, education and social care. By linking data, it may be possible to piece together warning signs for mental health problems which would not be detectable in single-agency data, but are detectable when combining multi-agency data. For example, a young person's teacher may have had concerns about their behaviour at school, and their GP may have also noted that they experience frequent infections, as well as the fact their parent has a mental health problem. But until this information is combined, it's not detected as a potential indication of the young person needing additional support. My project is split into 3 parts which build on one another. The first part is looking at what variables or risk factors should be included in an early identification tool if the tool is to accurately predict who develops mental health problems. To understand this, we carried out literature searches, had discussions with professionals such as social workers, and refined a framework of risk factors through a Delphi process, whereby experts in childhood mental health gave feedback over a series of rounds. For the second part of the project, I gained access to the Secure Anonymised Information Linkage Databank, known as SAIL. This is a collection of databases from health, education and social care, amongst others, which relate to the population of Wales. I've mapped the risk factors from the Delphi process to the SAIL metadata to see which factors can be measured and included in risk prediction models. I'll also use this databank to measure the incidence and prevalence of childhood mental health problems and their associated risk factors, including adverse childhood experiences across Wales. Third and finally, I'm carrying out an umbrella review of early interventions and prevention of mental health problems for young people who've experienced ACEs, in order to understand what can be offered to effectively support young people's mental health if we are able to identify at-risk young people earlier. I'd be really keen to talk through my project, so feel free to contact me during or after the event. Thanks.